Hi everyone, welcome to this session where we'll be talking about managing medication with Winston and Dr. Gurjit Singh Chokha. I hope everyone's looking forward to it as much as I am. Thank you both very much for being here. If you do have your phones with you and you can pop them on silent, that would be appreciated. And without further ado, I'm delighted to introduce Winston, who is going to introduce himself a little bit more and tell you a bit about his story. Okay, thanks, Winston.
I'm all right. You guys look nervous. Yeah, I'm Winston, and obviously you would have heard I've got Parkinson's, and my role this morning is to have a chit-chat, talking about medication. It's medication time, and we have with us Dr. Chokha, who'll be answering the questions that I can't answer, so don't pose those questions to me, and we'll just take it from there. Lighthearted. Those of you who are online, welcome. I know we have persons online from far away, and I want to welcome you. I can see you shaking at me. I know who you are, you know who you are, and also present in the audience. It's so wonderful to have you there, and it's good because you're going to make this one happy family. So, hang on. What? You know what? What have I done with my impromptu speech? Okay. Always be prepared. Got it here. You know, I have been diagnosed with Parkinson's. I had symptoms as far back as 2018, and was diagnosed 2 years ago, 2022. I've been falling prior to being diagnosed. I've been lightheaded, and I went to the GP, and she knows me. She said, "Winston, look, I'm not sure why you're shaking. Let's just take it further." And I had a chance to go and see the consultant. I'm from the Southeast in London, and I had a chance to go and see the consultant there. And the first thing she said was, "What should I call you?" I just said, "Call me Winston." Or a.k.a. Lionel Richie, because I like to say hello. And we took it from there. And she said, "Okay, well, I heard from Baz this morning spoke about propranolol. I was on that. That didn't help me." And we went further up in the field with that. We went on to some scans, DAT scans and so on, and then here am I. And it's so good with Parkinson's. I'm speaking from a mic, because you guys don't know if I'm nervous or have a tremor going on, isn't it? Okay. So what will happen this morning is that, or both, that we'll have a little chit-chat from me about my journey, and then I'm going to sit down there and you pose some questions, and we give you some answers. If you can't give you the answers today, we get them to you either via the post first class. Okay. So, the problem is with Parkinson's is the journey. It's a journey. And I have done something at home called the 4+ system. And this is my system. And if I can get it taken further than that, you can help me here, maybe publish it. A few months ago, I was waiting in hospital to have my assessment done. And I came across a quotation from a well-known American author and inspirational speaker called Zig Ziglar. Have you heard of him before? Yeah? And he said, fear has two meanings. Fear. One is forget everything and run. or face everything and rise? Which one do you think I went for? Yeah, talk to me. Rise. Why? Why? Sorry? I'm a strong person. Hidden symptoms again. No, I decided to face everything and rise. And when I went to my neurologist, we had a chat, and he said, okay, well, this is the program I'm going to put you on. When he got there, he said, bring a chair, Winston. Come bring a chair. Let's have a chat there. And I like that. He never, in the beginning, said, Winston, let's talk about Parkinson's. He says, I like your accent. Where are you from? I said, Barbados. I said, have you been there before? So I offered him an invitation to come to Barbados. And then he cleverly went into Parkinson's. Guess what he did for me? I had fear. So what did he do? He just calmed me down. He explained the process of the medication, which was levodopa. And he took an ordinary piece of paper and he just wrote down exactly what he wanted me to do. But he said, Vincent, what do you think we should do? Now, what he alone is going to do. So he involved me, and I like that. To cut a long story short, well, I went away feeling how I felt good that he involved me, because it's my journey. I have to live with it. But you know, I forgot what he mentioned about this levodopa. I forgot about it. So I went to my pharmacist. Nice lady, I knew her for 20 years. And I said, can you explain to me about Parkinson's? And she took the leaflet out of the package. And she went through it. So how many of you all would read that leaflet? Hands up. You got to. You may have some, what they call some posh words, some big words. Don't go for the internet. Forget that. The pharmacist. And she took me to her little consulting room there. Private. And she explained these things to me. But she said, Winston, were you given a Parkinson's nurse to help you out? Because the Parkinson's nurse is the bridge between when I'm going to go back to see my neurologist. And he's a lovely guy. Movement disorder. And I said, yes, I have a Parkinson's nurse. I was able to call her because in those days I had a 3-month appointment with my specialist, which I know some of you are saying, well, I haven't had one for 6 months, 18 months. I was just fortunate because where I live in the Southeast, it's a very closely knitted community there. And all the medical services that I require are located under one roof, so to speak. So it's the physio, it's the, who else do you get? Physio, speech, who else? Sorry? Occupational therapist? Anyone else? Dietitian. I had the whole lot. And that was good for me. So I had the neurologist, I had the Parkinson's nurse, I had my physio, and I also had the pharmacist. Okay? And that was my sort of connection there. But I didn't stop there. One of the problems I had with this medication, and I've had it mentioned so many times from yesterday and this morning as a side effect. What was it? Constipation. Let me tell you something, boy. Woo! Constipation. You know, over in the hotel we were staying there, the Holiday Inn, and I get these these weird dreams. Anybody get them yet? Oh my gosh, man! And yes, I had a bad one. And okay, I decided, well, look, I'm gonna try to see if I can get this constipation sorted out. So I went into the toilet, and have you noticed they have what they call, when one door is closed, the other one is open in a... You've seen them yet, those doors? You open one and close another one? And I go and I sat on the throne. Yeah? But before I got on the throne, I heard this voice say, Winston, you're constipated, but you're going in the wrong direction. Turn around. And I sat on the throne. I'm waiting for this thing to happen. And it ain't working at all. Ain't working. And then a voice said to me, Winston, be patient. I said, I'm being patient. Winston, be patient. Then I look up, and on the wall, this is a dream, you know. Something said, if you're patient, Winston, this too should pass. Yeah, and that stood with me. Family and friends, so important with Parkinson's journey, isn't it? You need good friends. You want your family to be with you, to share those moments. Because when I had the diagnosis, I was crying. You can imagine this 6 foot of crying, this ugly face, but I use a mirror. I use a mirror. Because when you look at the mirror, what does it tell you? What does it show you? How ugly you are, that's right. And I love laughter. I'm hoping that I can get a message through to the authorities to get laughter on prescription. Get it prescribed. It costs you nothing. If you don't have a sense of humor, get one before you leave Leeds. It's free. It's the best medicine in the world. And, you know, I'm not going to take too long because I know you have lots of questions. I'm hoping you're going to throw lots of questions to us. Throw the ones to me that I can answer, please, you know. Working with doctors. I trust the science. I'm involved in lots of trials, lots of studies, lots of group activities. I don't know if I should mention this to you, but there was a particular trial that was mentioned from this morning. I'm from Barbados, so you can probably work it out. I'm a very chill-out guy, isn't it? Yeah? So it's that one. Yeah, that one. It's going well. It's going well. And I want you to come on board with these trials too. Yeah. If you ask me to do something with a trial that is going to benefit you, I'm going to do it. Because my role is to see those persons who are on their knees, that I can go to them and say, listen, don't worry, I'm going to help you. There's nothing better to say to some person than, I can help you. For me, it's never about Winston. It's about, if I look good, you look good. So it's what I can do for you to make you look good. That's my style. So my friends, in closing, I want to make sure that your medical team is with you. You may not be as fortunate as I am to have all these persons around me. But you got to try. You got to try. I said earlier on this morning, so many people give up trying, not realizing how close they are to success. Don't give up. is so important in your journey? Parkinson's is relentless. It keeps coming at you all the time. And you have to find a way to be on top of it. I'm 71 years old, or young. And I want that when I die, people say, that guy, he made a difference in someone's life. Yeah. I don't have enough time left as what I had before. So why I'm retired, don't have to work, I spend my time focusing on what I can do in this journey with those who are affected with Parkinson's. Because as I've said to you before, if you look good, I know that I'm looking good. I've made the effort this morning, haven't I, to look good, okay? That's my style. So, my friends, you've got the power to make a change. We've got the power to make the change. We can do it together. Some years ago in Barbados, we had from the Rotary, I think it was the Rotarians, and we had a program there where we held hands around the island. I would love to see us holding hands in this journey to get one result. It may not be a cure for Parkinson's, but we can reduce the symptoms and make us feel good. We got to feel good, man. The feeling good is a wonderful thing, isn't it? We love better. We do so many things better if we're feeling good. You've got the power in your hands to feel good. You've got the power in your hands to rise and ignore Parkinson's. Put it on the back burner. It's there, but forget about it. Because we have the professors, we have the scientists, we have those persons who are working for us, and all they want is a good body to get these trials on to them. Audience, thank you. So I'm going to introduce our next speaker. He's going to talk to you about medication again, about medication management. Please welcome, if you're able to, put your hands together and welcome Dr. Gurjit Shaku.
Hello everyone, I'm Dr. Gurjit Singh Shoka. I'm a geriatrician, which means I predominantly look after older people, and I work here in Leeds, but I have a specialist interest in movement disorders and in particular Parkinson's. And Winston, you mentioned fear, and I've got a confession to make that I'm quite scared. The organisers asked me to come and talk to you all today about medicines management, and essentially what they're saying is, can you stand in front of a group of experts and talk to them about what they do every single day? And I actually had a bit of a misunderstanding. When they said, will you come to Park On, I thought they said Park Run. So I'll come and run in a park for a little bit. That's fine. I'll raise some money for Parkinson's UK. But then they said, no, it's Park Con. So it's about 250 people here, 800 people online, and you're going to talk to them all. Okay, but as scared as I was, as fearful and nervous as I was, I had to do it because I wanted to do it to say thank you. Thank you to the Parkinson's community because they've taught me how to be a better doctor. I guess you all know that Parkinson's has a wide variety of conditions, so I had to learn to listen I had to learn to listen to my patients, to the people I see, about what they want, what do they want to talk about. The Parkinson's community taught me about community, about how important it is to have people around you, have experts around you. And it taught me that when people come to see me, they're not coming to see me about disease or problems. They're coming to see me about life. And Winston put that really, really well. So really what I want to do with my time here is hear from you. I want to learn from you. So I'm going to quickly rush through my slides because it's more about how you manage your medicines. So there was some feedback about what you might want to hear about, and it was things like, what do the medicines do? When do we start them? How and when to take them? And what kind of things we're looking for, and what can you look for? So I'm going to hopefully talk about that quite quickly, but I want you to either ask me about these things if you want to know a bit more, and we can hear from the room, or I want you to tell me. So I think you all probably know lots and lots about Parkinson's, but just as a start off, the areas in orange and white there, that's the basal ganglia, and in the basal ganglia there's lots and lots of dopamine cells, and a lot of those cells deal with movement, and that's what's reducing in Parkinson's. So you might get some difficulties or changes in your movement, which might be a shake or stiffness or slowness, and this picture here shows you the dopamine released from the cell at the top, and then they bind to receptors at the bottom, and these are like messages that are getting sent. Because that's reducing, the aim of medication is to try and increase the amount of dopamine so those messages can keep going. And these are the types of medicines we use. I suspect you've all heard of these. Levodopa, which gets converted in the brain into pure dopamine. It's stored in that top cell and then gets released when you need it and binds to the receptors in the bottom cell. You can have dopamine agonists, things like ropinirole, pramipexole, and they do a similar job. They bind to the receptors at the bottom and they're trying to send those messages through. You can have MAOB inhibitors like risagiline and selegiline, and what they're trying to do is stop the dopamine being broken down so that it can hang around for longer. You can have higher levels of it for longer. And that's the same with COMT inhibitors. So that's things like entacapone, that might be in Stalevo, and opicapone. What I've tried to show with this graph here is what somebody's dopamine levels might be like throughout a day. So you can see that maybe there's more in the morning, and that's when you're most active, and things might tail off during the day. But this is somebody who is within that window where they're not experiencing any symptoms or side effects. But as Parkinson's progresses, that window becomes narrower and the dopamine levels become lower. So this is sort of naturally what's going on in your brain. But again, somebody's living well. They're not experiencing any symptoms or feelings that they might have Parkinson's. But at some point, unfortunately, things do start to change, and the dopamine levels that the brain produces will go down, and somebody might start to experience symptoms. So this is where medications might come in, and we want to try and lift those dopamine levels so that somebody doesn't experience symptoms. And something like levodopa, which we tend to give 3 times a day, you'll see the level go up after you take a tablet and then slowly come down, and you'll take another tablet and the levels will slowly come down, and you'll take your 3rd tablet. And the idea behind that is that we can keep you hopefully feeling like you were before you had the diagnosis or the symptoms. And we may use things like dopamine agonists or something like higher doses of levodopa, because again, we're just trying to lift the levels of dopamine in the brain so that people can live well. We might need to increase the times that you take them to do that. So this person might be taking the levodopa 4 times a day. Or we might use something like an MAOB inhibitor like selegiline, or a COMT inhibitor like a picapone. And what that's trying to do is slow the breakdown so that you get more benefit for longer. But remember that line at the top where somebody gets side effects. And if we go too high with the levels, you might start to experience some of the adverse effects that you get from the medication. And that could be things like low blood pressure, or it could be things like stomach problems, I guess, or dyskinesia, where you get some extra movements. And so what we want to try and do is keep somebody within that window, but maybe reduce some of the peaks. So we might give the medication more frequently, or we might use some of those COMT inhibitors and MAOB inhibitors or agonists, so we don't need as much dose as higher dose. And I guess this is where the management bit comes in, isn't it? It's how does this fit in with your life? How does this fit in with work, with looking after your kids, with family dues and social engagements and so on? And that's what I'm keen to hear about from yourselves. There are other medications that we might use to help us keep within that window. So modified release levodopa, which basically is absorbed slower and then hopefully wears off slower, but you get less of those peaks. The levels don't get as high. We might use dispersible levodopa, which is dissolved in a bit of water and gets absorbed really, really quickly so that you can get this boost, this quick action. We might need to use amantadine, which has actions that reduce dyskinesia, if that's something that you are having difficulties with. There's apomorphine, which is a really useful tool because it's injectable and it can work very, very quickly if people are having swings in their symptoms. Rotigotine, which is the only medication we've got that comes in a patch. And so if somebody might be having problems swallowing their medication, it can help give us a different route to get the medication in. And some of you may be on or may have heard of duodopa, which is a gel, and you have a PEG tube, so a tube that goes directly into your intestine, where this gel goes constantly throughout the day. And a newer drug, which I guess as a community we're all figuring out where this will fit in and how we'll use it, but phoslevodopa and phoscarbidopa, which goes in through a small needle under the skin and can go constantly throughout the day. And that can reduce some of those big ups and downs and give people more constant levels. So that's a really, really quick run through of some of the tools that we have to try and help you live happier and better lives. And I guess it's all around movement, those medications, but as you all know, this isn't just about movement. And Winston quite eloquently told us about constipation, but that can be a big burden. And so it's not all about dopamine. It can be about things like laxatives, and how important fluid intake is to help manage your bowels. It can be about managing blood pressure issues, so either too high a blood pressure or something I see more often, lower blood pressure, which might lead to lightheadedness or dizziness. Mood problems, so whether there's a role for other messengers that are in the brain, not just dopamine, but things like serotonin, for example. And sleep symptoms where we might need another messenger like melatonin. Some people have some issues with saliva, and there are loads of medications that we can talk about there. And some changes in thinking, I guess, with the condition or with the medication, and how we can maybe look at managing some of those. So that was a really, really quick run through, because I'm very keen to either hear about what you want to talk about in a bit more detail, or even better, how you manage your medications day to day. So if I could go to Claire, if there's any questions or if anybody wants to say something, that would be really, really helpful.
Thank you. Wonderful. Look, already hands shooting up in the audience, and there's mic runners, so they'll come to you in a moment. First, let's have a look. We've already got loads come in from online. So the first one I've got here is from Angela, and she asks, if recently diagnosed, what's the current thinking on the use of small dosage levodopa over boosters? I imagine she means like MAOB inhibitors and dopamine agonists.
So I think from my point of view, I obviously, with me being a geriatrician, so I tend to see older people. And that's typically, when I say older people, I'm talking about people over 80. And what comes with that is often other medical conditions, other problems, not just Parkinson's. And I have to sort of weigh up the benefits of medication, and people tell us, research tells us that levodopa is the best one for improving symptoms. You get more bang for your buck, as it were. But I also have to consider the interactions of things like dopamine agonists with their other conditions, with their other medication. I think if you're a lot younger, often Parkinson's might be the only medical diagnosis that you're dealing with. And one of the questions I would ask is, would you rather take a medication that you have to take at least 3 times a day because it lasts for about 4 hours? Or would you rather take 1 tablet once a day, which is where dopamine agonists can be really, really helpful. I think when I was trying to show that window of side effects and symptoms, I think the window's a lot wider when you're just diagnosed. But if you've just got Parkinson's, that's the only thing affecting that window. Whereas if you've got other conditions and you're a lot older, you might have things like heart failure, lung problems, kidney problems that narrow that window a lot more. So I tend to go straight for the levodopa for a lot of my the people I see. But one of the important things is taking into account your lives, your other commitments. Is it feasible to be taking medication 3, 4, 5 times a day, or is it better to have a tablet once a day, which is where I think the dopamine agonists can really come in. Did that answer the question?
Very well. Thank you very much. Let's see if we've got one in the room here. Come here to Andy.
Thank you. Increasingly, I seem to be faced with the choice of being functional with dyskinesia or being non-functional. I'm of quite an addictive personality, so I've always shied away from dopamine agonist family of drugs. So really I'm on levodopa and controlled release levodopa. And I wondered if you'd got any pointers that I might discuss with my medical team for how we can potentially address that.
That's a really good point, and thank you for sharing such personal details. I think what you've highlighted there is one of the side effects, and maybe one of the more worrying side effects with dopamine agonists. And as a doctor, I just hate it because, you know, I need to tell people, whether you're talking medico-legally or just on a personal level, about the impulse control disorders, where the medication might fuel some a behaviour that isn't typical for somebody, or it might fuel some addictive behaviour. And, you know, you're just giving somebody a diagnosis and then you have to scare the life out of them, unfortunately. But it's an honest fact. But it's something that should be monitored and we should all be looking out for. It's not a given, it's not a certain with the medication. And it rarely is it something that's just you wake up one day and it's there. There's usually a build-up. And as long as we're all educated and we all know what to look out for, that's really important. We can adjust the medication so that if somebody is showing some signs of impulse control, they're doing repetitive behaviours or things that seem to be not goal orientated, we can maybe adjust back down. So I think the first thing to do would be to say, speak openly about dopamine agonists. But if it's not somewhere you want to go, I think what I would be asking is about how do we smooth out those levels? Because dyskinesias, more often than not, are dopa responsive or dopa dependent. And it's those peaks when you tip into dyskinesia where you get them, and then as the levels come down, you may get less of them or they may be more manageable. Is that your experience, do you think?
Sorry. I think it possibly is, although yesterday I was completely dyskinetic all day, which was really unusual and a little bit scary, to be honest.
Okay.
And I don't know if the addition of a picapone into the regime, probably about 12 months ago, has possibly exacerbated the situation.
Yeah. So that's a really important point. I think another important point is that real life sort of gets in the way as well. I know a lot of people I see in clinics say, I'm fine, I'm not this dyskinetic at home, but it's just coming here. And I don't feel like I'm that intimidating, but obviously if you're seeing a doctor, it's a different situation, isn't it? And that can build up things like adrenaline and steroids, cortisol, all that sort of stuff, and it peaks that anxiety. So there's day-to-day life as well that can affect dyskinesia and make them worse. So there are lots of non-medication type of techniques that might help, things like meditation, calming techniques, breathing techniques, and it's what works for people. Where something like a picapone might come in is that the advice is to, when you start something like a picapone, you might reduce the levels of levodopa. But for me, I always feel like that's a bit nerve-wracking because somebody's already considering a picapone because they're not doing so well on their levodopa. They need a boost or they want to be better. So I don't know if reducing the levodopa at that point is the right thing, and sometimes I keep it at the same level and maybe think about reducing it should dyskinesias become a problem. So that might be something you want to reflect on. Did we just add the opicapone onto our usual levels, or did we at some point reduce them? What I was trying to show there was a whole day, and there sometimes can be a bit of an additive effect of each medication you take. So it could be that you don't need to reduce all of the medication. It might be a dose in the middle or a dose towards the end. There's the option of something like amantadine, which can help reduce some dyskinesia. And then it might be taking less peaks, so you reduce your individual dose of levodopa, but you have it more often if that's feasible. You can sometimes look at the other non-Parkinson's medication you're on if that's relevant to you, and see could any of these be driving, physiological other things in your body that might drive some of the dyskinesia. And just, I guess, the importance of other things like where that energy's going, exercise, are you getting good sleep, are you feeling a bit down in other ways, and is this something I can do on a day-to-day basis when I do have a lot of dyskinesia like yesterday? Is there anything I could do the day after just to try and take the edge off and that kind of thing? So having conversations like that. I'm a massive advocate, and I always ask a lot of the people I see to do this, whether they do it or not is another matter, but of diaries. So if you were able to keep a diary, a dated, like a hour by hour or 2 hour by 2 hour diary for a few days, doesn't have to be every single day, but for a few days before you go to a clinic, it helps the doctor or the Parkinson's nurse so much to see, is this a one-off? Do I think this was related to something that had happened a few days or a day before? Or actually, is there a pattern emerging that we can definitely modify with the tools we have? Winston, is there anything else you wanted to add to that?
No, in terms of the diary, I've been keeping a diary since 2018. Okay. And the problem I have with that is that I write things down, put them on the phone, I can't find them when I want them. So what I've been doing now is, if I have my appointment come up in the next 6 weeks, that's the time that I want to have the problems to pose to the doctor then, rather than a much longer period of time. And I find that works for me, having these snap questions, because you can't think you're going to remember them. Because when is your next appointment going to be? So, yes, you write things down, okay? Ask questions. Take someone with you. I made a fifth mistake by going to my first results on my own. I was crying in the park. Take someone with you. Because doctors love it when you can say, it happened on this particular day, as opposed to, I think maybe, I can't remember now, Be direct. And that's going to help. That's why phone has helped me. Yeah.
Great. We have lots of questions, so maybe we could have a few rapid ones, if that's okay, and then we might have to close. So from online, can someone please explain, I think they're talking to you, about taking meds and meals? Should they be taken on an empty stomach? And if so, why is it not a labelling requirement? And that's from Sarah.
I've seen bottles. People have brought their medication bottles or boxes in that say, eat with meals. And I've also seen the same medication bottle or box say, eat on an empty stomach. And it's really, it's about your life. I think that's the important thing, and something you can ask your doctors and your nurses about. The problem occurs because meals can affect the absorption of your medication. So if you have, for example, quite a lot of fat in the meal, it can delay the absorption so that it slows it down. You don't get that quick onset. You get a very slow rise in your dopamine levels. And if you have a lot of protein in your meal, it actually competes with the absorption of the medication, so you don't absorb as much of it. I think if you're newly diagnosed, the advice I give to the people I see is, don't worry about the meal thing. Fit these into your life how best works, and we can work around it. We can increase a dose if you need a bit more benefit. But what we certainly don't want you to do is stop eating or reduce your eating, or just be so debilitated by trying to fit in a meal, then your meds, a meal, then your meds. As the condition does progress, things might be more difficult for you, and actually the meal might have an impact. So it's about talking about it. It's about maybe journaling or keeping a diary about, oh, well, I had this meal and actually I felt a bit more affected by my Parkinson's afterwards. And so actually I think food is becoming a bit more of an issue. And we can then talk about timings and things like that. One of the great things about Parkinson's and seeing people with Parkinson's is that everybody's different. So I would just say, know your own experience, and if food seems to be an issue, then talk to us about it, and we can then help you to plan each day as you want to, so that you can enjoy your meals, you can enjoy the benefits of your medication, not be limited by them, and certainly not be anxious about events, meals, family meals, all that sort of stuff. Is that fair, Winston?
Yeah. If I can just quickly, before I forget, to ask you, you have you here. It's about, I don't smell anymore. I don't know if it happens with you. Taste, limited taste. Yeah. The only good thing about Parkinson's and that is that my wife, she says, take the bins out because I don't smell the bins, Yeah. But Is there any way that my smell, I know I've asked maybe ma'am, I think it's the dietitian some time ago, if it would return?
That's not my experience, and I haven't found anything that says it. There's something we can do, or there are medications that we can use to help it return. I think, and this isn't really for me to say, but this is just a personal question. Okay. Sometimes we're so busy in life. I know sometimes I'll have sat down for a meal and I won't have tasted it or enjoyed it. It's functional. I just wonder, Winston, is there something about taking the time to enjoy something, to consciously try and smell something? Does that seem to help, a bit of mindfulness?
Valerie, she would, to help me to enjoy the meal, make it look very colorful, you know. I go along with that. But come on, I mean, jerk chicken? So I have to pretend that I'm enjoying it, you know. Or if I try to cook something, I may hear, Vincent, it's burning. I can't smell it. But I will still try to eat it because, I mean, I've made the effort, isn't it? Yeah.
Oh.
And this is one of the problems, isn't it?
Is it time for the medication now? That's an amazing way to finish the session. I'm afraid we are out of time. I know we had lots of questions that we didn't get to, and I'm really sorry. I'm sure if you're here in person, you can come and speak to our speakers now if they're willing, and hopefully they're both around for the lunch break, so please do come and have a chat. If you're online and we didn't get to your question, please know that you can always ring the Parkinson's UK helpline. You can email us, and we will get back to you. There's also loads of great information on the Parkinson's UK website. But thank you so much to our amazing speakers, Winston and Dr. Singh Chokar. And thank everyone who's joined us. Thank you so much.
Just a quick comment to say quickly. So I've had lots of people come into me, like Winston said just then, and they'll give me a little wink and they'll say things like, "My wife's always making me take the bins out. Can you tell her that that's not good anymore? I really struggle with the washing up. Please don't put me in that position." That's between you and your partners.